You're listening to This Week in Cardiology from theheart.org on Medscape.
You can now access the latest in medical news on your Amazon Alexa-enabled device. Join me, Perry Wilson, every weekday morning for Medscape Medical Minute, where I highlight the top medical stories of the day. To add Medscape Medical Minute to your flash briefing, search for Medscape Medical Minute on Amazon and click Enable. Or open the Amazon Alexa app, go to Skills, search for Medscape Medical Minute, and click Enable. Then say, Alexa, what's the news? Or Alexa, what's my flash briefing? I hope you'll join us.
Hi everyone, this is John Mandrola from theheart.org Medscape Cardiology, and this is This Week in Cardiology for September 10th, 2021. This week, a second ESC wrap-up show. I'll revisit the Emperor Preserve trial, review the STEP, GUIDE-HF, and IAMI trials. First, a brief update on COVID. Thankfully, it looks like our numbers are on a decline, even in places like Florida. But hospitals, including ours, are at capacity, and it's going to be hard for the coming weeks, no doubt. And folks on the front lines of this have my respect. It's just very, very hard. Nearly every week, I think about how fortunate we were to have the messenger RNA vaccines available during this surge. I spend so much time in my EP clinic every week convincing hesitant cardiac patients of the clear benefit of these drugs. Now to cardiology. First, an update on my coverage last week of Emperor Preserved. Now, Emperor Preserve was a large trial comparing EMPA versus placebo in patients with heart failure with preserved ejection fraction. The trial found a statistically significant improvement in the composite outcome of heart failure hospitalizations and CV death, but it was driven by heart failure hospitalizations. CV death and overall death were not changed. My coverage on the podcast focused on the fact that heart failure hospitalizations represented a very small proportion of total hospitalizations, and a reduction in heart failure hospitalizations was not enough to significantly change all-cause hospitalization. And of course, that criticism stands. But I participated in a journal club this week on the trial, and two further points came up. One was the lack of overall death signal. Now, the lack of death benefit stands out because death rates were quite high in this trial. 14% of patients died in both arms. Now, you might wonder how this compares to other heart failure trials. Well, in the 1996 carvedilol heart failure trial, death occurred in 7.8% of the control group, yet that simple beta blocker could reduce death by 65%. And then in the 2011 Emphasis heart failure trial of eplerenone versus placebo in patients with heart failure, the death rate in the placebo arm was 15.5%, and the MRA drug was able to reduce all-cause death by a statistically significant 24%. Now, my point in this historical comparison is A, to say that it used to be commonplace for new heart failure therapies to reduce all-cause death. And B, I wanted to point out that as baseline therapies improve over time, it is harder to show big gains with new drugs, and that's important because new therapies will be hyped and they'll be very expensive. The second point in that journal club that came up is that nowhere in the New England Journal of Medicine publication is listed the percent of patients on loop diuretics at baseline. There's a table, S2, in the supplement, tells us about all other classes of drugs, but not loop diuretics. Now, the Emperor Preserved authors did publish a baseline characteristics paper in the European Journal of Heart Failure that does tell us that about 2/3 of both groups were on a loop diuretic, since one of the mechanisms of SGLT2 inhibition is via diuresis, and you had to have a high BNP to get into the trial, Emperor Preserved. I would have been very interested in a subgroup plot looking at the outcomes of patients on and off loop diuretics. In sum, I remain worried that the costly SGLT2 inhibitor class of drugs for the indication of heart failure with preserved ejection fraction will remain a low-value intervention. Next trial is the STEP trial. Now, despite numerous trials looking at blood pressure targets, the positive SPRINT trial, the null, ACCORD, and JTOS trial, the Goldilocks target systolic blood pressure number remains elusive. The STEP study group set out to compare an intensive systolic blood pressure target of less than 130 millimeters of mercury or standard therapy of 130 to 150 target. The trial was done in China, and the primary outcome was this vast composite of lots of different things. There was stroke, ACS, heart failure, coronary revascularization, atrial fibrillation, or death from cardiovascular causes. About 4,200 patients were randomized to each group, the mean age 66 and the mean blood pressure 146. Now, office blood pressure measurements were a bit more normal than in SPRINT. Here they were performed by a trained trial staff member, a doctor or nurse. Patients were required to rest for at least 5 minutes in a seated position, and then the blood pressure was measured by trial staff 3 times at 1-minute intervals. Now first, the two groups achieved their targets. The mean blood pressure in the intensive arm was 127 versus 135 in the standard arm. The follow-up was 3.3 years, and in the New England paper, you can see the two graphs, and there's clear separation of the two systolic blood pressure targets. Now, clinical outcomes. The incidence of any primary endpoint was 3.5% versus 4.6% for the intensive and standard respectively. The hazard ratio was 0.74, and the confidence intervals range from 0.6 to 0.92, so clearly a significant decrease with the intensive blood pressure target. Stroke, acute coronary syndrome, heart failure were all reduced with confidence intervals that stayed below 1. And safety in the STEP trial was pretty good. Hypotension was higher, 3.4% versus 2.6%. But low blood pressure was defined as less than 110. There was no difference in fractures, nor were there any changes in kidney outcomes. And the outcomes held up in all the subgroups. And visually from the plots, the intensive arm looked better in those with higher blood pressure and in higher Framingham risk, which you'd expect. So my comments, this is clearly a positive trial, but I think there are some important limitations. Now let's first look at the inclusion-exclusion criteria. Who were these patients? First of all, only patients of Han ethnicity were included, and the authors state explicitly that this limits generalizability. But the exclusion criteria, I think, are more important. They excluded patients with stroke, any MI or revascularization in the previous year, and a diastolic blood pressure of less than 60. I think this enrolls a pretty robust group of older patients. The evidence supporting that was that the death rate was only 1.5%. Contrast that with Emperor Preserved that I just talked about had a 14% death rate. Now, combine the robustness of this enrolled population with the fact that these patients are in a tightly regulated clinical trial. I suspect that it's going to be hard to duplicate the careful follow-up of a trial to the real world. So, pushing on blood pressure in more fragile patients in real life might be harder and more fraught with complications. One criticism that I did hear that I don't think is that important in this trial is that patients in the control arm who had blood pressures below 120 had their meds reduced so that their blood pressure would go back up to a higher target. And the criticism is that we wouldn't do that in practice. But the thing of it is this is a scientific experiment that set out to test the blood pressure target. And if there weren't differences in the blood pressures, we wouldn't gain any real knowledge about targets. The bottom line, if you have a patient like those in STEP or SPRINT, and they really wanted to do absolutely everything to minimize their cardiovascular risk, then going to the more intensive target is worth trying. But I would be very cautious in translating this data. Remember that the absolute risk reductions in this trial were small and the potential downsides are significant. The next trial is the GUIDE-HF trial. Now, whenever I hear this statement, if only we had more data, we'd be better able to manage this patient, I always think back to the many hours I spent at Indiana studying Swan-Ganz tracings and cases. More data from the pulmonary artery catheter would surely help us manage these sick patients in the ICU. Well, you all know how that went. Randomized controlled trials showed that the invasive monitor that provided hemodynamic data didn't really have an effect on outcomes. But now there's a device made by Abbott called the CardioMEMS. It goes into the pulmonary artery and it provides feedback and data that is designed to help manage patients with heart failure. The idea is that daily weights and observation for edema are not enough. The monitor in the pulmonary artery must be better. Give me granular data and I will fine-tune those diuretics perfectly, goes the thinking. And way back in 2011, there was a trial called Champion and found that the device managed patients that had a 28% fewer heart failure hospitalizations. But the problem with Champion trial back in 2011 was that A, it enrolled a narrow group of patients with New York Heart Association Class 3 heart failure who had a previous heart failure admission, and B, it wasn't powered for outcomes like mortality. Of course, given the expense and added workflow needed to manage all this data from the device, one should have a properly powered trial that enrolls a broader population of heart failure patients. And so here we have it, GUIDE-HF. At ESC, we learned the results of GUIDE-HF trial, and it compared the use of the pulmonary artery pressure data to standard care. Both groups in this trial got the monitor, but only one group used the data. The endpoint was a composite of total heart failure events and all-cause mortality. And crucially, the trial enrolled a broader group of patients who had class 2 to 4 heart failure symptoms and either a recent heart failure admission or an elevated BNP. About 1,000 patients were enrolled in more than 100 centers. Here we go. The rate of the primary endpoint was 0.563 per patient year in the monitor on group and 0.64 per patient years in the standard care group. The hazard ratio was 0.88 and the confidence intervals ranged from 0.74 to 1.05. And the p-value 0.16, clearly non-significant. So you say, no problem, this is a non-significant trial. We can relegate this PA monitor to the bin with the Swan-Ganz catheters and move on. No, that is not what happened. In perhaps one of the boldest attempts at spin I have seen in a good while, the GUIDE-HF investigators presented a, quote, pre-COVID-19 impact analysis that compared outcomes before March 20th. Now, this post-hoc analysis pointed to a possible benefit for the CardioMEMS guided strategy. In this post-hoc analysis, there was a barely significant 19% drop in risk, and get this p-value, 0.049 for the primary endpoint of death or heart failure. The effect was driven by a 24% decline in heart failure events with no significant contribution from a lower mortality. Journalist Steve Stiles has an excellent report on the Heart.org Medscape Cardiology, and in that report, he cites Dr. Larry Allen, a heart failure specialist at the University of Colorado, and I think Dr. Allen has the right quote. Here it is. While the technology is pretty amazing, the real question is whether it tells us something that we didn't already know that leads to improved care. Unfortunately, as tested here, it doesn't, or at least not enough to make a big difference. This is the same message, my friends, as the Swan-Ganz catheter years ago. It is fancy, it output lots of data, but it's not enough. If you're going to propose an invasive device, intensive data monitoring, and significant cost, the onus is on you to show clear benefit. GUIDE-HF did not demonstrate that. My friends, do not be distracted by an after-the-fact analysis of data. A final comment on this post-hoc analysis. And I want to be careful with my words here, but the attempt to convince doctors with such a reanalysis tempts me towards cynicism. Why? Because Abbott funded the trial and stands to gain sales from a positive trial. And perhaps worse, many of the authors have financial conflicts of interest with Abbott. Now, the authors state that they made this analysis in consultation with regulators, but that gives me little solace. The problem is that when people see this stuff in a place like The Lancet, they begin to worry about the other science that's published in The Lancet and other journals, and that is sad. Final trial is the IAMI trial. COVID has made us forget about influenza, but long before SARS-CoV-2, and surely in the future years to come, when travel patterns return towards normal, influenza will again threaten older patients with cardiovascular disease. At ESC, Professor Ole Frobert presented results of the IAMI trial comparing flu vaccine versus placebo in patients who were admitted to the hospital for myocardial infarction. The primary endpoint was a composite of all-cause death, MI, or stent thrombosis at 1 year. The background here is that guidelines have recommended flu vaccine for high-risk cardiovascular patients, but this recommendation was based on observational and small trials. So the IAMI trial enrolled about 2,500 patients at 30 centers, multiple countries. Half went to the flu vaccine arm, half went to the placebo. But sadly, during the pandemic, the Data Safety Monitoring Board had to recommend halting of the trial before it had attained the pre-specified sample size. Now, of course, this is different from the previous study because with the dominance of SARS-CoV-2, influenza incidence, along with other respiratory viruses, plummeted. Plus, the increasing illnesses with COVID would have made adjudication of events difficult. During the planning of the trial, the authors calculated that they would need about 386 events so that they had 80% power to detect a 25% reduction in the composite primary endpoint. But sadly, there were only 158 events in this trial, 5.3% of primary endpoints in the vaccine arm versus 7.2% in the placebo arm. That hazard ratio was pretty good, 0.72. So 28% reduction, and the confidence intervals range from 0.52 to 0.99, and the p-value was 0.04. The rates of all-cause death were 2.9% in influenza group versus 4.9% in the placebo group, so that hazard ratio is 0.59. Again, statistically significant reduction in all-cause death. CV death was also significantly reduced. And strengthening these findings a bit was the fact that 13% of the placebo arm crossed over to get the vaccine, but they were, of course, counted in the placebo group, and that, of course, would have biased towards the null. As far as serious adverse events, they were rare and not different in the two groups. The authors also included in their simultaneous publication in Circulation a meta-analysis of prior flu vaccine trials, which included 3 other RCTs in high-risk cardiovascular patients. The pooled estimate of CV death of the hazard ratio from the fixed effect meta-analysis of all 4 trials was really impressive at 0.51, with highly significant confidence intervals. There's no evidence of between-study heterogeneity, so a very strong meta-analysis when you combine all the trials. During the trial discussion at ESC, Professor Barbara Cassidy emphasized the main limitation of the paper, and that is the early termination reduced the power to detect differences. The authors also led their discussion of limitations with this problem. And I feel terrible for them because this looks to be a well-run trial, and COVID could not have been imagined during the trial planning. Now, the point about early termination is not so much the possibility of a false positive result, but more an accentuation of effect size. There's an important paper I want to reference. This is by Bassler et al. In JAMA in 2010, and I'll put it in the notes. It's a really important systematic review and meta-analysis of truncated versus non-truncated trials. One of the main findings of the Bassler paper was that large differences in treatment effect size between truncated and non-truncated RCTs, that is, the ratio of relative risks of less than 0.75, occurred with truncated RCTs having fewer than 500 events. And of course, in IAMI trial had a hazard ratio lower than 0.75 and far fewer than 500 events. So it's possible that the effect size was exaggerated. Okay. But the thing I'm thinking is that even so, the adverse effects of a flu vaccine are minimal to none. And given the strong probability of some benefit, maybe it's not 0.72 hazard, it seems wise to vaccinate older adults admitted with myocardial infarction. A final point, some may wonder how the flu vaccine reduces cardiovascular outcomes, and I do too. But I would also add, as Professor Cassidy said, it doesn't matter how it works. That it has been shown to work in multiple RCTs is enough. Okay, now a final summary point. I intentionally bookended this podcast with the IAMI trial at the end and Emperor Preserved in the beginning. In the IAMI trial, we have an extremely low-cost, low-burden intervention that reduces important outcomes like death and CV death. In Emperor Preserved, we have an extremely costly pill to be taken every day that reduced a surrogate outcome of heart failure hospitalizations and had no effect on mortality, nor renal outcomes, nor really quality of life. One therapy is a high-value, steep part of the curve intervention, and the other is a low-value, flat of the curve intervention. Okay, friends, I've gone on for 20 minutes, and there's still more to cover from the ESC meeting. There's going to have to be an ESC number 3 show. That'll be next week. There are more notable studies. In fact, there are 2 post-PCI antiplatelet trials, and oh boy, is this space complicated. Did you all realize that these trials, these post-PCI antiplatelet trials, they have different patients, different stents, different durations of dual antiplatelet therapy, and for the win, different antiplatelet drugs. Next week, I'll cover the Master DAP and Stop DAP ACS trials. So that's it for this week in cardiology. As always, I'm grateful that you listened. Thank you. And remember, if you like this podcast, it really helps to take a few minutes, write us a review, give us a rating. That helps others find us. Until next week, this is John Mandrola from the Heart.org, Medscape Cardiology.
You're listening to This Week in Cardiology from the Heart.org on Medscape.